Okay. Good morning and good evenings. Even though you are in America or in Asia, daytime and nighttime, even in Africa. Yeah, you're in Africa right now. Yeah. So welcome to join the 113th webinar ICC. Today we are so happy have the Professor Karen Wong to come here to share her experience about Cleft-Q. Originally, she was the founder and the one to invent this the questionnaire for all those who care the cleft patient all over the world. Before Professor Tinchen Lu give a brief introduction about Karen's, I have introduced three of our panelists today. First one is Jordan Stamberg. He came from Florida, Nicholas Children's Hospital. Hello, Jordan. Hi. And the second one is Tin Chen, Professor Lu. I come from Chang Memorial Hospital. Hi, Tin Chen. And the third one is Professor Makoto Higosaka. And Professor Higosaka had ever to give the similar the presentation in ICC to share the all over the Japan, this the huge country, about how he organized all the Cleft-Q to audit and evaluate the patient has the good care or not. And now he served as the National Center for Trial Health and Development in Japan. So now we invite Tin Chen to give Professor Karen's introduction first. Thank you, Tin Chen.
Okay. So Dr. Karen Wong Reeve is an associate professor at the University of Toronto Department of Surgery and a pediatric plastic surgeon scientist at the Hospital for Sick Children. Her interest is focused on patients' reported outcomes in plastic and craniofacial surgery. She led the development of several international recognized patient-reported outcome tools, including the Cleft-Q, Face-Q, Craniofacial model, and Ear-Q, which are used globally to measure the patient's perspective on healthcare outcomes. These tools have been licensed for use in over 40 countries. Dr. Wong Reeve also interested in developing surgical simulators. She helped create simulators for cleft palate, cleft lip, and cleft alveolar bone graft surgeries, which are used to train surgeons outside of the operation room. Those surgical simulators are used by SmellTrend, are now used worldwide. Today, it is our pleasure to invite Karen to give a speech here, and let's welcome Dr. Wong.
Thank you, Chang, for the kind introduction. Hi, everybody. It's such a pleasure to be here. I'm always so happy to see the Chang family again, as it has a very special place in my heart. Just as a disclosure, I am the co-creator of the Cleft-Q, the Face-Q, Craniofacial module, and the Ear-Q patient-reported outcome measures. And I do receive royalties when these are used by for-profit companies, and I can tell you that that is never. But if it ever was used, I would receive royalties. But it's important to note that these tools are free for use by academic institutions. So I would encourage anybody who's eager to use them to look that up, and I'll show you how to do that later on. So I had the good fortune of coming to Chang a long time ago, and a lot of the faces that are on here today are in this photo, but I would argue some of them look exactly the same. But this was back when I was in my fellowship, and I got to spend some time at Chang on the Cleft team, and it was a really special time for me. I've made some lifelong friendships and connections with people from all around the world, and it really helped to solidify the importance of a global perspective when we come to any kind of cleft surgery or plastic surgery in general. So this is my home hospital. This is the Hospital for Sick Children, or Sick Kids as we like to call it. We're in Toronto in Canada. It doesn't always look this sunny here. It'll start getting a little bit chilly here soon. But so far we're still in good weather. This is my current division. I included two members who recently retired. Dr. Howard Clark in the top left corner, who's a hand and nerve surgeon, and then Dr. Ron Zucker, who might be well known to many here. He is a pretty amazing all-rounded plastic surgeon who had a huge role in Operation Smile and in cleft care around the world, and really helped to inspire some of the global perspective that I'm going to talk about today. When it comes to cleft care at SickKids, there are three of us that do sort of the primary cleft repairs. That's Dale Podolsky, who is the primary, he's an engineer by training. He's a really smart and hardworking individual, and he's really driven the development of the simulators. The man in the middle often needs no introduction. That's David Fisher. He's really the mentor that encouraged me to get into cleft surgery. And the three of us together work together on our research projects, but also we will do all of the lips, palates, and alveolar bone grafts for our own patients. And then we pass them on to the sort of older patient craniofacial surgeons, Dr. Chris Forrest, who also needs no introduction. He's been our chief for many years. Dr. Joanna Rizal, she's a relatively new addition. She's a force to be reckoned with, and is also very involved in global health. And Dr. John Phillips, who you see here, who's just been an amazing craniofacial surgeon for many years. He's actually retiring at the end of this year, at the end of this academic year, unfortunately for us. So I think it's important when you do any kind of study or any kind of certainly qualitative work when you're talking to patients, when they teach you qualitative methodology, they say it's really important to know yourself first. And so I think it's important for all of us to sometimes reflect on why we became a cleft surgeon. For me, it was one of these moments when I was in residency. I happened to be able to go on a trip with Dr. Fisher to India, and this is us operating there. And I really got inspired by being able to provide cleft care globally, and to be able to try and advocate for equal cleft care around the world. Now, when we got back from that trip, I was speaking to one of our fellows who at the time was a visitor from, or she wasn't visiting, but she was a fellow at SickKids from Boston Children's. She said there's a lot of controversy around these mission type trips. And we were discussing this in terms of trying to build local capacity for cleft care. And I went to David Fisher and I said, this is what the controversy is, what are your thoughts? And Dr. Fisher is a very reflective kind of person. And he told this story and he said, once upon a time, there was a man who lived on the beach, and every day he would walk along this beach. And every morning when he woke up, there would be hundreds and hundreds of starfish that walked up onto the shore. And one day he was walking along the beach, and there was this little boy who was also on the beach, picking up a starfish one by one and throwing them back into the water. And he said to this little boy, why are you bothering? Because you're never going to be able to save all the starfish. And the little boy bent down, he picked up a starfish and he threw it into the water. He said, well, it mattered to that one. And so, Dr. Fisher was trying to say, whatever we can do in any small way to try and make it matter to somebody is important. And I think that for me begged the question, what exactly matters to patients with cleft and craniofacial conditions? And it's really important in cleft care in general, I think, to try and evaluate our care using outcomes that are actually important to patients. When you think about what we're actually trying to accomplish in cleft care, this is a quote from a patient from Kenya. When we asked, she was talking about what it was like to look at herself in the mirror. And she said, yeah, I never even used to wear makeup, nothing. Because even if you put on makeup, don't help. So at least now, maybe I can use a bit of gloss, something like that. Because I didn't even want people to look at me twice. Maybe it not matter to someone who looks at you and looks at you again, just to see how they see right. It's very discouraging. And what she was telling us about is what patients will often tell us, which is that they just want to be able to walk down the street and not have people look at them a second time. And they kind of wanted to sometimes just not be noticed at all. And that ultimately is kind of the goal. And so when it comes to actual outcomes and defining success, generally speaking, in all of medicine, we should really be using clinically meaningful and scientifically sound outcome measures, because these are really the building blocks of evidence-based medicine. Now, the World Health Organization defines health as being a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So instead of measuring, there's no more cancer, or there's no more heart disease. We should really be measuring like how well is the patient actually doing. And this is the international classification of health. Basically, it's a model that includes the biological, social, and psychological domains that all contribute towards an individual's health. Now, the FDA in the US defines clinical outcome assessments as being patient-reported, observer-reported, clinician-reported, and performance-based. And now when they try and approve any drug in the US, at least, they really require all of these applications to include the patient perspective. So these patient-reported outcomes have slowly become more important over time. So when we're choosing outcome measures, we always I tell our trainees when they're trying to develop studies and that sort of thing, really take a step back and what are you really trying to achieve with the intervention? What is actually the best way to measure those goals? Then what's the most feasible way to measure those goals? And finally, would a patient care about this chosen outcome measure? Does it matter to them? So very quickly, I know that you've already kind of heard this before, but patient-reported outcomes are reports that come directly from patients about how they function or feel in relation to a health condition and its therapy, without interpretation by a physician or anyone else. And these can include every aspect of a patient's treatment outcome. So it's not just about quality of life per se. It can be about symptoms, it can be about satisfaction or process of care, in addition to health-related quality of life. And essentially, these tools are like a ruler. And if they're developed properly, there's a lot of science behind a ruler. You can't just kind of draw a ruler and think that all the notches are going to be at the same distance. Those rulers really need to be clinically meaningful and scientifically sound. Now, patient-reported outcomes are not new. In other fields, they've really been able to help evaluate patients at a very high level. These are just some examples from the literature where PROs have been shown to measure surgical outcomes more precisely than observational techniques in orthopedic surgery. So better than range of motion in a knee or something like that. PROs, when you ask the patient actually about their function and how they're doing, they actually are better at evaluating those outcomes. And this one was really interesting, where patient-reported outcomes can actually predict post-operative mortality better than these subjective assessments, observational assessments, and blood work. So, blood pressure and ECG and blood work in adult non-cardiac major surgery. So when you can actually predict mortality, you know that there's something behind these patient-reported outcomes. And so we may not be talking about mortality, but I think that they can really be quite powerful in looking at the outcomes that are of interest to our population. So many years ago, we started the Cleft-Q project, and the idea was to develop an instrument to measure outcomes in patients with cleft lip and palate that was clinically meaningful, scientifically sound. And just because of this experience that we've had, as a group, it really needed to be applicable to patients both in high income and low and middle income countries, in high resource settings and low resource settings, so that we could create a ruler that would be applicable all around the world. So initially, we went to 6 different sites around the world to do qualitative interviewing, where we actually just went and talked to a number of patients. We did all of these interviews with people with a variety of different cleft types in these different countries. And from that information from the patients directly, so we didn't make up any questions ourselves. It all came from what patients told us. We came up with this conceptual framework that included the domains of appearance, spatial function, and health-related quality of life, and then subdivided within those domains to the scales that now exist that you see here. So a lot of people will say oftentimes, why don't you just use some of these other instruments that are involved? And I just want to show you this very quickly. When we code the content, and it's purely just the content, so it doesn't even matter how it's measured, or, there's a lot of arguing in the psychometrics world about which way of, creating scales is better than another. But the most important thing about any scale is its content. So I'm going to go through this fairly quickly because there are a lot of words here, but I just want to show you that what patients with cleft told us is on the column on the left, those check marks on the left. The 3 columns on the right are content that we coded from generic measures that are pretty commonly used, like the PEDS-QL, for example. And you can see basically that the boxes don't overlap. So not surprisingly in cleft, these are the concepts that our patients think is important to do with like positive psychology, voice and speech, sucking and chewing, and scars. But in these generic measures, they're asking more about energy and drive, sleep, attention, memory, and pain, which is not really relevant to our patients. Similarly, in the domain of body structures, the content is different. In activity and participation, that it's more about communication, obviously, with speech, interpersonal interactions and relationships, whereas for generic measures, they ask more about mobility, and our patients really are not necessarily affected with respect to their mobility. The relationships that they have is important, and this is not measured quite so much in the generic measures. And then, and from all that, you can see that if you use these other measures, you're not actually going to capture what's important to our patients. So it may look like they're doing amazing, and because they don't have any issues with mobility or pain, when in reality, the issues that are important to them are not actually being asked about at all on these other measures. So that's why it's important to use a tool that is really focused on the outcomes that are important to that group. So from that, we came up with these scales, and then we went and tested all these scales, a long version of the scales, in all of these sites that you see here. This field test included just over 2,400 patients from 30 different sites around these countries that are shown here. We are really grateful to all the sites that participated and contributed so that we could really make sure that the tool would be useful internationally. ICHOM is a group that looked at trying to streamline the development of an outcome measure set, and they adopted the Cleft-Q quite early. And from that, we were able to start looking at, how do Cleft-Q scores change with various factors. So for the appearance scores here, and this is a little bit of a busy scale, but you can see in general, patients' satisfaction with their appearance tends to go down over time, with the exception of teeth, and that's thanks to our amazing orthodontists, I think, where they're able to actually improve the appearance of teeth over time. But in general, we kind of know this with teenagers and young adults, where in the beginning, they're not as aware of their appearance, but as they get older, they become a little bit less satisfied. We showed that with age, speech satisfaction with speech function also decreased in some of the older patients. And this may be related to the fact that the patients that are still seeking care at older ages are likely to have VPI that has not been completely resolved. When it comes to psychological and social functioning, we found the same pattern where that would also decreased over time with age. In general, females actually scored lower on the scales compared to males with respect to the appearance scales, as well as the psychological well-being scale, which is maybe indicative of some of the challenges that girls will face when they're young. And from this, we can really start to drill down the differences between the different cleft types. So this is all just to show the power of these types of tools, where when you have a more severe cleft, it's maybe not surprising that those patients don't do as well. So the red line, this is a radar chart that shows all of the different scales in one chart, basically. And so each spoke of this wheel represents a different scale, and the score on the scale is indicated by the dot. So the red circle here represents the scores of patients with complete cleft lip and palate. And not surprisingly, those scores are a bit lower than those that have a cleft lip and alveolus, or cleft palate only, or a cleft lip only. I'm going to just skip over that, but we published a paper just describing this even in greater detail, where patients with different cleft lip and palate subtypes can be separated out as well. And these can now be used as sort of reference numbers as we move forward. What was really interesting and exciting to us from a methodologic perspective was that you can actually, the scales will perform the way you expect them to perform, which just is additional validation that they're functioning correctly. So speech function and speech-related distress scores decreased as the severity of the cleft increased, which is it was fitting with the hypothesis that patients with a worse cleft tend to have worse speech. Then we started looking at factors that relate more to access to care, and those who have access to early surgery, which we defined as being before 18 months, they tended to do better than those that had late surgery with respect to appearance of the face, as well as psychological, school, and social well-being. And not surprisingly, that was maybe the difference was the most obvious in kids with the speech function and speech-related distress scales. Now, this is a table that I show with caution because I think it's really important for people around the world to not misinterpret this. I think that so when we looked at the data based on country income level, we found that patients tended to have higher scores when they were being treated at a center in a high income country. But I think what this really highlights is not that, you know, the treatment teams are better in high income settings, because I actually don't think that that's the case. I think it's actually access to care. It's the people that are showing up, the time at which they're showing up, and the resources that they have available in these low resource settings is not the same as what it is in high income countries. So, for example, with speech therapy, oftentimes it's really difficult to have speech therapists available in the low resource setting. And so those patients really can't benefit from that resource. And also, patients tend to be followed more routinely in high income settings. And so we're able to see them at a routine follow up, whereas getting any sort of follow up is often quite difficult in a low resource setting. And so I think that these numbers can be used for advocacy purposes to say, you know, this is the value of having multidisciplinary care and access to care. And this is what we can do to try and support optimal care globally. So going back to the story about the starfish now, I think the real value of these scales is when you can use them in real time. So if you ask the patients to fill them out beforehand, and then you compare them to the mean scores of patients with a similar type of cleft in a clinic setting, you can actually visualize in one shot like this. You can see this patient with the red line here is doing really well with regards to speech, and overall is, you know, around the mean score for appearance and all of the health related quality of life scales. And you contrast that to this patient, patient B, who you can see at a single glance is not doing well from all perspectives, and their scores are significantly lower from an appearance, function, and health related quality of life perspective. So this is someone who needs a little bit more attention. And the great thing about these scores is that you can see this before you even walk into the room if they've filled out the scales before coming in. So in terms of being able to measure these instruments globally, the Cleft-Q has been translated into 32 languages and counting. Every day we're getting more requests for different languages, which is really exciting. This translation process is not as straightforward as someone just kind of translating the language, because oftentimes it also needs to be it's a cross-cultural adaptation. So as an example, there were kids that would tell us in North America, when they were talking about um, the impact of having a fistula or an open cleft palate, they would say, you know, I can't blow into a woodwind instrument, so they can't play the clarinet or they can't play the trumpet. And contrast that to patients in countries, in low middle income countries where they've never even seen a trumpet before. Their issue is more, you know, I can't blow on a fire. And so while the concept is the same, the way that it manifests is different. And so it's important in the translation process to make sure that not only does the language, is it the linguistic translation similar, but also the content needs to be appropriate for that cultural context. So we help to try and facilitate that process. And this is just an example of the different publications of the translations that have taken place into all of these different languages. As Ting mentioned before, the Cleft-Q has been adopted in more than 400 sites in more than 40 countries and counting, and it's really exciting to see. And you know, we're trying to support these efforts as much as possible, but it's really awesome to see just that this ruler, essentially it's just a ruler, it's a scale to allow us to now start to measure the same thing around the world, so that we can really start to understand our outcomes from a global perspective to a greater degree. Some of the studies that have come from the Cleft-Q now have been quite powerful in that we can see that patients that need surgery have lower scores than those that have had surgery. And that holds true for patients who need jaw surgery, rhinoplasty, speech surgery, and lip revision, as you can see here. And those that never needed surgery at all tend to have the higher scores. And so again, this is kind of just validating that the scales are working the way that they're meant to. But it shows also the power of just asking the patients, because they can maybe tell us what we need to know without us needing to take tons of photographs and measurements and images. This is maybe the most exciting part, where people have started to use the Cleft-Q and publish about the Cleft-Q who are not me or my team. And so this is a paper that came out of the Children's Hospital of Philadelphia, where they implemented measurement of Cleft-Q. And it was really interesting because they would do their regular visit with the patient. They had the patient fill out the Cleft-Q beforehand, but they didn't show that to the clinicians. And they didn't disclose the Cleft-Q results until after the initial visit. And what they actually found was that it changed practice when they did talk about the Cleft-Q results, and it just revealed, I think, more about what the patient was thinking than had come out of the actual just kind of face-to-face conversation. So that just sort of highlights the power of the communication that it facilitates between the caregivers and the patients and families. These are just some examples of how the Cleft-Q has been implemented, and publications that other people have put out there about the Cleft-Q. This last one is kind of exciting, where it's actually a genetic study that looked at the psychological well-being of kids using the Cleft-Q, and they showed that those that have this genetic difference actually have worse psychological outcomes, which I think is a really powerful tool moving forward as well. This is another study that came out of the Children's Hospital Philadelphia group, and this was one that was maybe a bit surprising, but also really important, I think, for us to identify. What they found was that 17% of patients that showed up to this cleft clinic reported a lifetime incidence of suicidality. That to me was really high and shocking. And they also found that lower Cleft-Q scores correlated with endorsing suicidal ideation. And importantly, that a Cleft-Q psychological function scale score of less than 70 identified suicidal ideation with 73% sensitivity and 66% specificity. So, you know, it can almost be used as a screening tool, again, to really identify who is in need of further mental health referrals that we may not always ask about at the outset of a clinical visit with patients. This is part of my the Cleft-Q team. Kareem Jogum, who you see here, he is actually a former patient of our craniofacial program, and he's now a researcher with us. And this team, while we're small, Alex is a new resident, Jesse Howard is a new speech language pathologist, and Simone Fishback is a speech and language pathologist. A lot of them have been now looking at what can we actually do with these numbers that will give us some more information about how patients are doing overall. So it's not just about measuring Cleft-Q. We never want to say you should only measure Cleft-Q. It's more, let's measure Cleft-Q along with these other standard objective measurements. And that's, I think, where the power lies. So we did a study to look at the correlation of Cleft-Q scores with some objective measurements to help us understand our patients better. And what we did was we compared Cleft-Q scores to speech scores in patients with either a cleft palate or cleft lip and palate. And we've also tried to compare them to anthropometric measurements from photographs in patients to really understand what the interaction is between objective measurements of speech and appearance and the patient's feeling about how those outcomes come out. So at SickKids, we use the SickKids Cleft Speech Score, which is just a way to communicate really between the speech and language pathologists, who are much smarter when it comes to these things, and the surgeons who just need to look at a single number. And so, you know, this is what we use. This score tells us about hypernasality, nasal emissions, and turbulence, compensatory articulations, hyponasality, and a general score of speech acceptability. Simone Fishback and Paula Kleiman, our speech therapists, are actually going to be talking about this in Kyoto in a month or so, but this is the score that we use. So what we did was we compared that Cleft-Q speech, the Cleft speech score, that score I just showed you, to Cleft-Q scores in this population here. And so we had a range of patients, and you know, fortunately in this cohort, it just turned out that most of the patients are doing quite well with respect to speech. You can see most of the patients are in that cohort with the blue bar on the left, which means they're kind of doing as well as you possibly could with regards to speech. But despite that, the red squares here show where there was a correlation, a significant correlation between the Cleft-Q speech distress scale, speech function scale on the right, and then the psychological function scale, school function, and social function, reflecting health-related quality of life scales. And what we found was actually the strongest correlator between the Cleft speech score and the Cleft-Q scales was actually the presence of compensatory articulations. So it's kind of interesting that you can tell, patients don't necessarily recognize their level or degree of hypernasality. It's what the manifestation of the hypernasality is, which is essentially those compensatory articulations and whether someone understands what they're saying or not. And so this is just an interesting way to now understand Cleft-Q scores even better, and also understand how patients are reflecting their speech back to us. I'll just go over that quickly, but the next category of measurements we looked at was anthropometric measurements. Leslie Farkas is a pretty famous plastic surgeon in Toronto, certainly, and he's the one who really developed a lot of the research around these anthropometric measurements. And I'm sure many of you have seen this picture on the right with all of the different dots that we use, and that's all thanks to Dr. Farkas. On the left actually this is actually the same form that David Fisher used and developed for measuring all of our cleft lip repairs. So before every repair, we will record all of these different measurements, and it helps us just to understand the cleft before we even get started, but also it helps us look at the data afterwards. So we have all of these measurements available to now correlate later on. For this particular study, we took 14 of those anthropometric measurements from two-dimensional photos, and then we did these calculations using ImageJ software on those photos. And what we found is that calculating individual lengths and ratios may not actually be the best statistical method, because I'm not sure that you can correlate one specific difference or ratio of symmetry in the absence of considering the context of everything else. So what we're trying now is a different mathematical approach to looking at that, which is trialing and network analysis to look for signals in the data. And I think that eventually with machine learning and AI, we'll really be able to understand these values to an even greater degree. Briefly though, I think what we found is that upper lip vermilion height symmetry correlates with the face scale score, the overall appearance of the face scale, as well as psychological, school, social well-being scales, as well as this appearance distress scale score, which is a newer scale that we developed with the Face-Q Craniofacial module. And I would encourage anyone who's using Cleft-Q to use this scale as well, because initially we didn't want to include anything negative in the Cleft-Q scales. We didn't want to say, I don't feel good about myself. But what patients actually told us eventually was that this appearance distress was actually important to them. So we wanted to measure a scale where we could kind of try and quantify how much distress are you having related to your appearance. So that is the only negative scale in the whole suite of scales. But upper lip vermilion height symmetry correlates with both of those. And then upper lip projection relative to the lower lip, which reflects maxillary hypoplasia, is also correlated with the lip score. And ultimately, it actually was also correlated with some of the overall health-related quality of life scores too. Now, my research mentor when I did this, and my PhD supervisor, Dr. Ann Klassen, who's really spearheaded the development of all the Q suite of scales together with Andrea Pusick. She developed the breast Q first, and then the body Q, the face Q for adults. And she said to me when I was talking to her about this, she said, I hope the scores don't correlate with the measurements. And initially I thought, oh my gosh, but it would be so great if they did, because it would tell us what's really important. But what she was saying is that there's so much more that goes into someone's perception of their appearance and their perception of self than measurements can show you. And that's why these scales are important. And so I think being able to understand, the patient where they say they're really upset with their appearance, but the measurements all look great, that would maybe tell a clinician this is not the best surgical candidate, because they're already pretty symmetric. So there's something else that we need to do to help them feel better about their appearance. And it's not necessarily an operation. And I think for surgeons, it would really help us to target our interventions as carefully as possible, so we're not just operating on everybody for the sake of operating, or for our own perception of their appearance, because we've all had these situations where you have someone come in who looks fantastic, we think, but they're really unhappy. And then you have the flip side where you have someone come in and you think to yourself, oh, I should have done a much better job with whatever it is, but they come in and they say, I think I look great. And so then you'd say, okay, great, I'm not going to do anything. So these numbers and the correlation between them, I think, is really important for us to consider moving forward. This is just an example of that network analysis that shows that this is a correlation matrix where the thickness of that green line shows how strongly those scores are correlated. This is just a correlation matrix that shows that interaction between the Cleft-Q scales. But where I think this is going to get really interesting is when we start to look at objective measurements and combine that into this matrix to really fully understand the complete picture of outcomes. So really the true outcome, and just to summarize what I just said, it really comes down to combining our understanding of standard objective measurements together with these patient-reported outcomes. So moving forward, what about younger kids? So we developed the Cleft-Q for self-report because we thought it was really important to understand what the patients, I think what parents think is really important too. We've also had all the situations where the parents come in and they're not happy with the appearance, but you ask the child and they say, oh, I think I look great. And so, we really wanted to focus on the patient perspective. Having said that, so many of our interventions in cleft care actually take place in kids that are under the age of 8. And so we're now adapting the Cleft-Q for a caregiver proxy report, which means that we're asking caregivers to try and answer on behalf of their children. We're very fortunate to have just gotten a CIHR grant to support this. And these are the different sites that are involved in that study. And the international sites in Bulgaria, Bolivia, Chile, and Thailand are supported by this organization, Transforming Cleft, which is an NGO based in Toronto that focuses on providing, on supporting multidisciplinary, complete team-based cleft care in low resource settings. At the same time, we've also now initiated an international registry for cleft lip and palate so that we can all just start collecting data. And I think that this is such an important thing for us to do on an international scale, so we can all try and measure the same thing. So that when we talk about results, we can actually compare results between other groups because the measurements that we use are the same. And so we've started this registry that includes those sites that are supported by Transforming Cleft. And we're now just trying to collect all data moving forward. And I think hopefully we'll be able to grow this. But I do think that in general, for all sites around the world, we should really be trying to collaborate as much as possible in order to get to a better final outcome. So to conclude, I think, in general, the more we measure, the more we'll understand. And I think what's really important is that the more we measure what's actually important, the more we'll understand. And I think that's a really primary focus as we move forward. I think this seminar is such a great example of globalizing cleft care. It's pretty amazing to see all the people that are on today, and thank you for joining from all around the world, from all the different continents. And then, this is also reflected in these meetings. This is the Chang Gung Forum that I had the good fortune of coming to last year. And, if you see the faces in the audience, again, they're coming from all around the world. And it's such a special opportunity we have in the cleft care community to really come together for the sake of our patient base. So this is the website where you can download the Cleft-Q and the Face-Q Craniofacial module. Again, it's free. You just have to sign a license through McMaster, which is very easy to do. And all of the papers that I was speaking about can all be accessed through that website as well. Please feel free to reach out to me anytime for any questions and collaborative projects. We're always open to further group work. And then finally, at the bottom there, those are our funding organizations that have supported all of this work over time. Thank you for your attention.
Thank you, Professor Wong, for the amazing talk and also for sharing with us the story behind the creation of Cleft-Q, and also for showing us the Cleft-Q results and the correlations to other conditions as well. So at this time, I'd like to invite our panelists for some panel discussion. So the first doctor that I'm going to introduce is Dr. Jordan Steinberg. Jordan?
Hi, thanks so much, Karen. This is fantastic. And in fact, I wrote down like 5 things, and then you progressively got to all of them, and I think pretty much addressed all the questions that I had. But yeah, I was particularly curious about this discrepancy with the parents because, when we think about, for example, like microtia surgery, and, many of us are, of course, waiting for older ages for reasons related to the surgery and things like this, but we're always wanting to know, what does the child feel and what is their thought, and making sure they're invested in the process for, participation and outcomes. But when it comes to clefts, of course, we're always operating under the principle that, doing the repair is always the right thing. For example, even in a case of a microform cleft, and we don't have the opinions of the patient in that instance. But I'm just curious about this issue of child ascent and as it pertains to revision surgeries. And for example, how do you now utilize some of this information to guide situations where there could be that discrepancy with what the parent thinks?
That's a great question. So I think the one of the great benefits, I think, of having this caregiver proxy measure, first of all, we're really trying to emphasize to the caregivers, we're not asking for your opinion. I think while the caregiver opinion is important, it's not as important as the patient's opinion. And we'll say the purpose of this scale is to know what the patient thinks. So we want you to tell us, what does your child think about their appearance or their speech or their well-being? And a lot of them in the early qualitative work that we've done so far have said, they're not really aware of their appearance yet. And so they can't actually act as a proxy. And in some ways, I think that's actually informative for parents. Or if they do then talk to their child and say, hey, what do you think about how your lip looks? And the child says, oh, it looks great. And maybe that just fosters a little bit more understanding between parent and child, for the parent to recognize, the child isn't really bothered by this right now. So maybe we can wait when it comes to revision. I think that, I think there's always going to be this interplay between the parent, the child, and us to figure out what the best timing is. And there are some situations where that there's probably going to be something that will bother them eventually. So at some point, that microform becomes an incomplete, and then at some point that incomplete becomes a complete. In an ideal world, we wouldn't fix any of them because we would just accept people's differences, but we don't live in an ideal world. And so figuring out what that border is I think a really difficult thing. And just being able to communicate with each other, parents and child, parent and surgeon and child, and all those different relationships to try and tailor that solution to that parent is going to be helpful. I think, what we should, that this is a philosophical kind of perspective, but I think as a community, when I see parents, the first thing I say to to them when they come for the first visit is, wow, your child is beautiful. And because they have a difference, but they're still beautiful. And I think that parents need to be given the permission to think that. And so hopefully we can try and change that perspective to really encourage that coping and resilience to be developed in the kids. And I think a lot of that comes from the parents at first.
Thanks.
I don't know if I really answered the question.
Yeah, no. And
TBD.
I'm glad you touched also on this issue with the difference between the professional ratings and the patient perception, and particularly as it pertains to speech, because we'll have this situation so often where there may be objective measures, whether it's the nasometer or something like this, where a child's speech is rated by the professional as perhaps being suboptimal, but there's no patient or family perception of an issue. And I'm curious about this third sort of arm of the triangle, which is, as you have the patient perception, you have the professional rating, and then you have, let's say, how the rest of the lay public, perceives that. And I wonder about the interplay of that as well, particularly in a time where people are now reporting on a lot of these informal sort of crowdsourcing perceptions too.
That's a great, it's a great question, or a thought basically, because really a lot of how people feel about themselves is because of the reaction of others towards them. And so from that, that quote from the the woman in Kenya at the beginning, she just wanted, it's the grocery store test, quote unquote, where they just want to walk through a grocery store and not have people ask, what's wrong with your face? Which is such a horrible question, but I think it happens to these patients all the time. I think that one of the things we're doing from a methodological perspective is actually trying to figure out like what is quote unquote a normal score. So we're trying to do normative studies now, or not normative, but we're looking at what scores are in kids that don't have clefts. And if we can kind of just get a sense of where people are at with perception of their appearance, this is, I think, something that's not typically been studied because the tools haven't been available, but understanding how people feel about their appearance from a numbers perspective has always been difficult. There's body image and there's self-perception of other things, but not truly a measurement of what do you think about how your face looks. And I think if we can show that there's this variety in this population that doesn't have a cleft compared to those that do, we can maybe start to try and influence from an advocacy perspective about facial differences, because we all have facial differences. It's just the type and the degree that varies ultimately. But you're right. I mean, it's really the lay public eventually I don't know how we're going to change that.
Thanks. Thank you very much.
Thank you, Dr. Steinberg. Next, I'd like to invite Dr. Ting-Chen Liu.
Hi, Karen.
Hi.
I don't really have a question, but I think the measurement on the photo is very important regarding to the Cleft-Q, because it's very interesting to know the vermilion height asymmetry has a lower score, because right now we know the vermilion height is a problem for the kids. Yes, so I think that's very important. And I don't have,
I agree.
yeah.
No, that's okay. I think, I was actually hoping to find a lot of correlations, because then it could be like, oh, what do we really need to focus on in this repair? We really need to focus on getting this vermilion height symmetry, or it's the vermilion, or, whatever it is. And I think that, what Anne was saying from a research perspective, she's like, no, that's not what we want. And so that interplay between what we're thinking from a surgical perspective is different. But I think that when you drill it down to the individual patient, because we're looking at statistics of lots of patients put together, but when you talk to that, it'll allow us to discuss with that individual patient, like, if we fix the vermilion height asymmetry, do you think you'd feel better about yourself? And they'll say yes or no or something, and say, okay, so then that's what we'll do. And it might not be, the shape of the scar up on the lip. It's actually this that bothers them, or maybe it is the shape on. So it'll really help us, I think, ultimately understand how patients are feeling better, and maybe guide us as surgeons better in the future too.
Yes, that's very good. Thank you very much.
Thank you.
Thank you, Dr. Liu. Next, I'd like to invite our our panelist from Japan, our expert, Dr. Makoto Hikosaka.
Thank you. It's such an honor to see you here, Dr. Karen Wong. I noticed that Cleft-Q does not have questions about nasal obstruction. Do you understand my question? And I believe the Cleft-Q was developed from the words of the patients themselves. So at the development phase, did you have any complaints about nasal obstruction from your patients?
It's a great question. So when we were looking at the tools that were available, some of them did talk about it, and that it is important, particularly when it comes to the septum. But there is a scale out there already, the NOSE scale, NOSE. And when we looked at it, we thought, this scale is fine. And so we don't need to recreate that within the Cleft-Q. So the Cleft-Q sort of filled in all the other gaps. But I think for those patients, and I think, for a lot of our palate patients, certainly pharyngoplasties, but maybe even all of the cleft patients that have a septal deviation, maybe using the nose scale more widely would be important. And in that that ICHOM set of outcome measurements, the nose scale is included in that one.
Thank you.
Thank you for coming on today.
Thank you, Dr.
I was sorry.
Okay, last but not least, I'd like to invite Professor Lunzo Lo for some comments. Professor Lo.
Yes. Hi, Karen. I so happy to listen to your talk. And initially, I thought I had question, but really, after listening to your talk, I do not have question. But I would like to say that the outcome measure, the patient-reported outcome, really is very important one, and it should be done in many kind of study. And Cleft-Q really provide a good outcome assessment instrument for in this field. And I would like to thank you for your contribution, and also would like to continue to see your application and study in this field. Thank you very much.
Thank you for coming on today. It's such a privilege to have you here.
Thank you, Professor Lo. So next we would go on and proceed to our Q&A session. So we have a couple of questions from our audience. The first one is from Dr. Penthe, and the question is that for places where they do not have psychosocial counselors or psychologists in their hospital or in their team, how can they predict suicidal tendency among their patients with the help of this tool? Is that possible?
Yeah, so I think that is one of the most powerful outcomes that I wasn't necessarily expecting. But what the team at CHOP showed was that if you administer the scale and they have a score less than 70 on the psychological well-being scale, that they are at risk of suicidal ideation. And so I think ultimately all of the Cleft-Q scales, I always envisioned it as possibly being a screening tool. It's so difficult in these settings to try and bring people in for a follow-up visit just to ask, like, how are you doing? If you could just send them these scales to fill out, and then we can set and identify thresholds where we know that below this threshold, now we need to bring this patient in. Now this patient needs more resources. I think that would make it a lot easier for us to reach these patients that can't physically present. We have the same issues here in Canada. Our catchment area at Sick Kids is enormous. So we have people coming from 8 to 10 hours away to our cleft center, and it's really difficult sometimes to get them to fly in and stay overnight and that sort of thing. And so, being able to do this remotely where we can get a good understanding of how they feel would really be helpful. So I think if we're able to administer the scales, and right now we're doing it over a REDCap or on a tablet or something like that, that's fairly easy to set up. So as internet becomes more widely available in these sites, then I think that that would really be one of the strengths of being able to use this tool.
Okay, and our next question is from Dr. Tanikawa, and the question is that she's very interested in implementing the HM outcomes analysis, correlating the PRO with objective measurements. So for HM, are there any references grading the outcomes, like a central database, or does each center uses their own isolated analysis?
It's a great question. Hi, Dr. Tanikawa. So I think that ICHOM provides the set of outcomes for free. There is no central database. And so you can set up your own either on Excel or through REDCap or whatever system that you have. They have people at ICHOM, I think, that can support it. I think some of it has gone into the value-based healthcare in high resource settings where they're really trying to establish that these hospitals are providing value. And so a lot of that is in settings where hospitals are money-making ventures. But I think that they are still willing to support the implementation in other sites. Now, when the ICHOM database was developed, the outcomes database, was Alexander Alori at Duke. He actually has a really great REDCap database that's available, and he's willing to share. He has a central repository, but it's housed in the US, and we actually can't even be part of it because legally there are too many hoops for us to jump through to send data to be housed in the US, which is why we had to do our own. And so you can either take those outcome data points that are in that Excel spreadsheet on ICHOM and build your own Excel database or REDCap, or we can try and set up something central. This would be my pipe dream, that everyone who's on today, we all somehow figure out a way to make it easy and to facilitate it. So for example, the sites that we're including now in the international registry through Transforming Cleft, we're housing that database at SickKids and REDCap, and we've signed data transfer agreements to be able to have those sites be able to access their own data and enter their own data.
Okay, and we have one more question. It's the question is that they have gone through the Cleft-Q questionnaires, but were unable to differentiate the questions for the psychological part. But to my understanding and to what you explained, I think we're looking at the psychological part as a whole rather than a portion of the
Correct.
Cleft-Q, right? So would
Yeah,
you
so
like
this
to
is actually
expand on
really,
that?
yeah, this is it's a great question. So you actually, there's a scoring system. So it's not as straightforward as just adding up the numbers. That has to be transformed. And so when you sign the license for the scale, you'll be sent all of that information. So you do end up adding up the scores, but then it transforms to a number out of 100. The scales are not designed to work as individual items. So each one of those items works together, and it's kind of like a hierarchy. They're set up so that the question that's at the top of the scale is usually the easiest one for patients to say yes to, and the one at the end of the scale is the hardest for them to say yes to. And the pattern in which they answer those scales really dictates the final score. So the items, the individual questions on the scale should not be used in isolation. You need to fill out the whole scale and then calculate the final number based on all of those answers.
Okay, thank you, Professor Wong. And that's all for the Q&A session.
Okay, thank you.
Thank you so much.
Thank you, Junior. Yes, Karen, I have one personal question about the Cleft-Q. How frequently you, in your idea and in your thought, you can audit your multidisciplinary team to how frequently you can make once more for those, maybe you can make it as a longitudinal evaluation for the Cleft patients. Yeah, I believe once your team is not strong enough, you can to figure out the result of a Cleft-Q. Yeah, because so I'm just wondering how frequently you will perform once more the Cleft-Q questionnaire for your Cleft patient or Cleft parents or Cleft surgeon teams. Yeah, how are your suggestions?
So I think there are two approaches to this. One approach, this is a great question, by the way. I could talk about this for hours, so cut me off if I'm talking too much. But one approach is in the regular audits. And so I think in the ICHOM database, they have certain age groups that they've defined. And I think a lot of that was based initially on the AmeriCleft and EuroCleft studies. And so I think there's a 5-year-old, an 8-year-old, 10, 12, or something like that. And I think each team does that differently, depending on your capacity to have these multidisciplinary regular team assessments. I don't think that those like very standardized years of assessment are as realistic to carry out in low resource settings, because it's so hard to get patients to come in for follow-up anyways. And just to say hello sometimes is maybe not the best when they're not having any clear issues. But having said that, I think it is important to be able to track our outcomes over time, because Cleft Care takes 20 plus years to come to its completion. So I think each program can kind of define that themselves. For us, it's ideally it'll be 3, 5, 10, 12, and then something around 15 to 17, and then after orthognathic surgery. Which for us, because of COVID, has been supremely delayed right now. And so we sometimes have like 25-year-olds coming into SickKids. But I think that the other really powerful use for it is before before and after surgery. So on an individual basis and not for audit purposes, when someone's coming in and they are interested in a rhinoplasty, we should be administering all those scales before the rhinoplasty and then after the rhinoplasty, and then we can understand what the difference was based on that. And so we're trying to tailor it to each patient's stage of care so that you can fill it out whenever you need to. Having said that, they don't need to fill out every single scale every time they come, because I think that's just too much burden. And so oftentimes it'll be, you know, if you're coming in for a rhinoplasty visit, you just fill out the nose scale, maybe the face overall appearance distress, and then the psychological well-being scale and the social and school scales. So you don't have to do all 12 of them, because it might just be too much time and too much burden for the patients. But that, I think that pre-op, post-op for me, I think is actually where the valuable information lies. I see in the chat that there's the question about differentiating the questions. If people don't answer all the questions and they leave some blank, there are ways to deal with the missing data. If there's too much missing data, then you can't really calculate a score, but you can sort of impute it in statistical terms. But that should all be in that package that comes. And if it's not there, then reach out to me, and I'm happy to talk you through it.
Okay. Junior, do we have any more questions from the chat rooms?
Yeah, actually, that was the question that Karen just answered for us. And also, I think Dr. Tanikawa also asked her whether you keep the comparative individual data in REDCap.
Yes, we do. So our hospital is on Epic right now, and so Epic as an EMR, I'm not sure how many people use Epic right now. It's great in some ways and also very burdensome in other ways. You can put Cleft-Q into Epic, into these EMRs, but it won't actually calculate the final score for you. And so for just ease of data management, and also because we're collaborating with sites that don't have Epic, we've been keeping all of our data in REDCap for the time being. REDCap is supposed to be able to talk to Epic and back and forth, and hopefully with other EMRs as well. Just to add one more thing to the center that's using the scales and having people not answer all the questions. The other thing you can do to try and overcome that is once people finish the scales and they hand back the tablet to you, you can actually review those questions and say, you know, there are some that are left blank. Would you mind filling them out? It's important to have them done. And so it's a little bit more work on the person who's administering the scales part, but it's really helpful when you get complete data. Or sometimes you just encourage them at the start and say, it's really useful, and actually the scales need you to fill out all of the questions, so please try not to skip any if you can avoid it. Usually one or two that are missing is okay, and hopefully it's not more than that.
Okay, thank you. Thank you, Karen. Just like Professor Lowe has said, thank you for your contribution in the CLEP world for everything to making our CLEP care better and better. And finally, we have one faculty, Charles, and he would like to introduce our upcoming event in Chang'an. 2 weeks later, we have this year annual Chang'an Forum. So allow me to give us some minutes to briefly introduce this event. Please, Charles.
Okay, hi everyone. Now it's time for us to share what's coming up. We are thrilled to let you know that the Chang'an Forum 2025 is happening this September 29th to October 1st. And the program won't just have the keynote lectures. We also have live surgeries and also orthodontic hands-on workshop. It will be a great opportunity for learning and exchange. So mark your calendar. We can't wait to see you in Taiwan. And our next mission will be the bidding for Cleft 2033 in Kyoto. We are excited to meet all our friends there, and we sincerely hope for your support. So now please take a look at our video.
It sounds like a silent. Maybe Professor Low can give us some narration.
No sound. Maybe I tried to like play here. Does it have sound?
No, it's still silent.
No sound.
Yeah, Charlie, maybe try again. Like
Yeah.
Hmm.
How about this?
right now it's not playing. So
No sound.
no sound, no audio. I mean, no video.
Okay. Well, sorry. Just a moment. I tried
Mhm.
again. Mm. Oh yeah.
Never mind.
Share the sound. Yeah.
Okay, you can play again.
Okay. I can play it again. Okay.
We're still not seeing any video right now. Oh, there we go.
Yeah, good.
Do you hear the sound?
No, still no sound though.
No sound.
No.
No sound.
No problem. I can do the narration.
Okay. I just
Taiwan is
keep.
a safety, yeah, and
Okay. I
Taiwan is
just.
easy to reach. Yes, and visa is very convenient for all of you. And it's simple and fast to get a visa. And in Taiwan, you all can afford all the expense in any food and accommodation. And in Taiwan, it's really safety, and you can take all the bus transportation everywhere. No matter you lost of anything, nobody will take it away. It's very safe. And this is our new building to hold the 2033, the World Congress of Cleft. And this is a very nice place in Taipei and very close to our airport, very nice MRT station and away behind. And this is quite huge. Taiwan has a lot of very nice, beautiful scenery, mountain, oceans, 101, night market especially, and we have several temple and we can lantern sky. Okay. And we already have very good experience to holding the international congress, not only the Chang Forum as well as the APCA and the ALCPA as well. And 2 years ago, in 2023, we have hold a 3-in-1 international congress in Grand Hotel in Taipei. I believe all our participants is very familiar with that beautiful hotel. Yeah, so welcome to Taiwan. We are all a family and we are all a friend. Yeah, thank you. So this is our purpose to, yeah, this narration is quite nice, right? Professor Low, would you like to give us the closing remark, please?
Yeah, I would like to have many of you to support us to have the meeting 2033 international prep meeting in Taiwan, and I would like to see you in Taiwan. And thank you for your support.
Thank you all. And I would like to invite all our participants, the audience in ICC, and it's a good time to have a group photo, please. And please turn on your screen. Thank you so much. And I will take a group photo. Oh, careful driving, Daniela. Very dangerous. Hello, Luca from Italy. Nice to see you.
Hi, great
Professor
to see you.
Honda. Hi, Kate. Okay, I will count to 3. Hello, Professor Fayaz. Yeah, thank you, thank you. Count to 3. Give me a smile. 1, 2, cheese. Thank you so much, and thank you for your coming. 1 month later, I believe we will meet in Kyoto, and Taiwan need all of your help and all of your support to hold the event in 2033. Thank you all, my friend. Thank you again. Good morning and good evening. Bye-bye. Thank you very much. Yeah, thank you, Luca. Oh, careful driving, Daniela. Don't see anymore the computer in the phone. Thank you, Karen.
Thank you so much.
Bye.
Thank you,
Thank you
Professor
so much.
Fayaz. Thank you.
See you in Kyoto.
Very nice
Yeah,
presentation.
can't
Yes,
wait
See you
see
in
you all in
Kyoto.
Kyoto.
Yeah. Great.
Yes. Yeah, thank you, Luca. Milan 2024 ECPCS is quite nice, very perfect. Yeah, so good, so good.
Thank
Okay,
you.
have a good day.
Okay,
Have a good day.
bye everyone.
Bye.
Everyone.